ICD-10 education session. We're going to have one of these every month for 3 hours, and the schedule of the classes is posted on our salemhealth.org/ICD-10 website. Did I say it right? I think so. If you have trouble getting access to that website, just let any of us know, Linda or Judy or I, and we can help you with it. But all of the ICD-10 information that we're trying to gather to help not only our facility but the community facilities as well is going to be on this ICD-10 website throughout the next year and a half. This is a huge endeavor, a big project. Our hospital is really lucky that we have executive staff that recognize the importance and the impact that this transition is going to have on our facility as well as everyone else. And we are fortunate that we have a project and a project manager that is really driving this forward. So we want everyone to take advantage of the resources that are available and to please reach out if you have questions or if you need more support in that regard. So make sure you're asking us for things if you need anything that you don't see on that website. I'd like to introduce Claire Norton, Dr. Claire Norton. She's our physician advisor in the back for our CDI program. Claire's been really integral in working with the physicians at the facility to try and get them to understand the importance of documentation improvement in ICD-9, and we all know that folks don't necessarily document as well as they could now. But we also had Dr. James Kennedy come from FTI Consulting, and he gave several presentations to our physician groups trying to show them the impact of what ICD-10 is going to have on their documentation in the future. So we've got a lot of things going on, a lot of initiatives towards this effort to try and get everybody on board with ICD-10. I think you guys are going to find that once you start using it, you're really going to appreciate it. You're really going to like it. It's more rational, and it provides the specificity that everybody's been wanting for the last 30 years. So with that said, I will introduce our ladies that are in charge of our education. So to my left is Linda Dawson. She is our CDI coding knowledge expert. She's an RHIT. She's a teacher at Portland Community College. She is our subject matter expert for coding within our department. She works with the CDI and the coders together to try and make sure that we're capturing all the documentation that we need to ensure our billing is accurate. And then Judy Parker is our Coder 3 currently. She's she's heavily involved in the education piece within our department. She's been one of our lead inpatient coders for quite some time, and she is helping in this effort to try and move over to ICD-10. Both of these ladies are ICD-10 approved trainers. So we really have an advantage of having these experts at our disposal. So please, as you go back to your facilities, if you're from outside community facilities, please pass the word that this session is available to our partners in the community. We want to fill up this auditorium. So you're welcome to bring anybody that you want that's interested in coding. Who knew? Okay, I'll leave it up to the ladies. Thank you.
Good morning and welcome to our training on ICD-10. I'm going to start off with a little joke, and I need Landis up here for this. He showed me this morning, and I just can't. Yes, I cannot go without doing this. We're going to keep our day as lively and relaxed as possible since we have a subject matter. You know, we have to learn a lot. Okay, so this is what Landis showed me this morning. He says, absorb, absorb. And that might work for somebody that's telepathic, you know, but for the most of us, we're going to have to be doing this. Oh, yeah, just keep reading and reading, going over. As we're going through our chapters in our training, go over your chapters. This is what I teach my students, is to open up the chapter in the tabular, maybe not so much in the alphabetical, but in your tabular, and go through there and see what's in that chapter that we're studying for the week. And that'll acquaint you to some things that you've probably never seen, never coded before. And I think that'll be a good start for coding. And Cindy already gave you my background. I coded ICD-10 in Canada about 10 years ago when they went live, and coded for about 2 years up there. We did not have books. We had an electronic book, which was kind of nice. You could put your own notes in it. But I like having a book so I can see it, which I'm really glad that they let us get books for this training, and that will help us out a lot with our coding practice. The encoders that we had up in Canada worked really well. We had 3M, and it worked really well, so I think ours will work fine here in the US. We have our own clinical modification that has been put forth for us, and so we have a lot of experts in the field and infectious disease and specialties that have helped come up with this clinical modification, and hopefully we'll be able to not find anything that's missed. But I think, you know, if we find things that are missed that we don't think are right, I think probably we'll have the opportunity, just like we did with ICD-9, to put those forth and say, there's no code for this, where do I put it? So as you're going through, keep a list of things that you maybe don't think are right, or maybe they're in the unspecified instead of the specified, that type thing. So I guess we'll get started. So this is our month training session, or March training session for the month of March. And our compliance date is October 1st, 2014. It's on a Wednesday, so it's going to fall in the middle of the week. I don't know if they're going to push for us to get all of our coding done by the time it goes live, or as much as possible, or what facilities are going to do. But it's probably a good idea so that when you switch over, you don't have to try to have two things in your head at once, the 9 and 10, even though they're really not that much different, just the guidelines. And a little bit about the history of ICD-10. We are now in the 10th revision. I learned the 9th revision in 1999 when I was coding years ago, and it was written by the World Health Organization, and we are one of the last industrialized nations to adopt ICD-10 with our clinical modification. And so why do we code? Well, we all know that years ago it used to be for statistical purposes only. They wanted to know how many pneumonia patients we had, and the way we captured it back then was on an 8x10 card. When I worked up at the medical school, there'd be a pneumonia card, and we write down every patient's name and number so we could keep track of our patients, everybody that had pneumonia. But now, with computerization, we can get out really advanced and advanced statistics. We do it for continuity of care so that we know what we're treating our patients for, and that's why it's really important to include everything the patient is being treated for, either in the outpatient or the inpatient setting. It's used for billing, as we all know. And our form should be up to date when we go with ICD-10 to be able to take all the letters and numbers and the length of the codes. And it's also used for severity of illness, which is really important right now for justifying for billing for the insurance companies about our patients. It goes for statistics. They want to know how many patients with pneumonia also have diabetes, hypertension. It just makes the patient more severe if the more diagnosis they have that they're being treated for. So it's really important, even in the outpatient setting, to capture the severity of illness. And what do we code? So we all know for outpatient coding, we code the reason for a visit. Whether they come in with chest pain, abdominal pain, they're tired, they're weak, they have had a stroke. And then on the inpatient, we code by the reason of admission. And we get that information from our physician order, from our emergency room dictation, from our history and physical dictation. And then we come up with a final DRG. So in the outpatient setting, the guidelines are that we do not code any probable or possible diagnosis. You only code symptoms in the outpatient setting. So if your physician tries writing rule out MI, rule out lung tumor, things like that. You really need to educate him and let him know that we can't code rule out, so he can't use it. He needs to give us a symptom. So here's an example. Patient came in with syncope, and the physician states it's a possible TIA. So we know we can't code the possible TIA. We have to code the symptom of syncope. And here's an example of an outpatient visit, like for a lab or x-ray visit. The physician, if he would code a rule out pneumonia, we can't code it. So basically, we have to go back to the physician's office to get what their symptom was. Were they coughing? Did they have chills? Do you hear something weird going on in their chest? They have ralls. And so basically, any symptom code can be used, but no probable possible diagnosis. So for coding our complications and comorbidities, these things are what drive our severity of illness. So in this example, a patient seen for diabetes with neuropathy, with hypertension, hyperthyroidism, obesity with a BMI of 44, and CAD, or coronary artery disease. So we code all conditions that are being treated that visit, either with medication change, counseling, follow-up lab, etc. And this affects the overall patient's care and severity of illness, which is very important these days. And it also justifies our E&M level charge. So if you charge one E&M level, but there's not much in the dictation, the written notes, you may not get paid for that E&M level. So here's definition of a principal diagnosis does not apply in the outpatient setting. It's your reason for visit. If the physician doesn't identify a definite condition or problem at the conclusion of the visit, the coder should report the documented chief complaint as the reason for visit. So a patient might come in with abdominal pain, and that's all you know when they leave the office, is yes, they had abdominal pain. You can't code any rule outs or possible. So in this one, the patient complains of right upper quadrant pain. Appendicitis has been ruled out, but it might be irritable bowel. So we can't code even the irritable bowel in this case. We can only code the right upper quadrant abdominal pain unless he gives us a diagnosis that has not been ruled out. So at this point, in the outpatient setting, we need to alleviate us in the hospital bothering the physician's offices for codes, because it's a waste of both of our time. So if the physicians will just document a good diagnosis, even if it's a symptom for that lab or x-ray, then we'll be able to code it. And there should be a reason for every test. So if you're doing a hemoglobin and you have a diagnosis of toe pain, that doesn't really go together. So you need a reason why you're doing that test. So sometimes they'll do a whole battery of tests. Just make sure that there's something that's going to show for every single lab test. And like one patient might have tiredness, they have a thyroid panel, they have a hemoglobin hematocrit, and maybe one other test, and those probably can all be used with the diagnosis of tiredness, weakness, weight loss, so just making sure that you have a diagnosis for every condition the patient's having a lab x-ray test for, and no probable and possible. So in the inpatient setting, we confirm diagnosis, we code all confirmed diagnosis, as well as all probable, possible diagnosis on the discharge summary. If we have a possible or probable within the chart, but not on the discharge summary, and we think that the physician still is treating them for that possible diagnosis, we need to have that added to the discharge summary. And then also, if you see that they have a test, like say they have a chest x-ray or they have an echo, and the patient doesn't have any diagnosis in the whole chart that goes with that, but maybe in the progress notes that you saw, patient was having some chest pain, but he doesn't really list that as a diagnosis, then that could be a reason for that test. We need to justify every test that we're doing to get paid for them. So here's an example of a review. Patient admitted with left herniorrhaphy and extremely low potassium level is noted on the lab report. In examining the physician order, intravenous potassium was ordered. The physician has not listed any indication of an abnormal potassium or related condition within the medical records. So what do you think the best course of action would be? For our people that do this all the time. Query, okay, so you can, and in the outpatient setting in a physician's office, you can just ask him, what does this mean, you know? So he can give you a diagnosis of the hypo or hyper condition, like the hypopotassiemia on this one. Here's another one. So you confer with the physician and request a condition to be listed as a final diagnosis. And here's a rationale that you can read later. So in the inpatient setting, patient has an EKG, troponin level, or other test, and has no history of CAD. Patient's admitted with chest pain and no other cause is found to substantiate the testing, so we will code the chest pain. So Judy found this really cute little picture, and I thought this physician looked like, what is this ICD-10? Which a lot of them are saying. They're scared to death, and there's no reason, because there's no way they're going to be able to learn every code so that they can put it on their orders for lab and x-ray or whatever they're having done. As long as they know the medical terminology that is needed for us to code it, that's all they need. We don't need numbers because we know how to code. And this is just a definition of the Uniform Hospital Discharge Data Set. And I included this for our CDI experts and then also for maybe outpatients, so you know kind of what we do in the inpatient setting when we're finding the principal diagnosis. So it's a condition established after study to be directly responsible for the admission of the patient to the hospital. We review the whole record, maybe not so much nursing in great detail, but we will look at the progress notes, the discharge summary, histories, consults. We look at lab values, we look at x-rays, we look just about everything. We cannot code from everything in the record, but we can look at everything and see if there's maybe something that was missed in the documentation. So basically the words after study are important, but their meaning is sometimes confusing. It's not the admission diagnosis, but rather the diagnosis found after workup or even surgery that proved to be the reason for admission. And we need consistent, accurate data. If one physician says it's this, one physician says it's pneumonia, the other physician says it's not pneumonia, it's CHF. So if there's not 3 times when, or in the discharge summary, what says that patient did have pneumonia, we need to query the physician to clear that up. And then if we don't see the CHF documented anywhere, so our query could be, did this patient have pneumonia, congestive heart failure, pneumonia and congestive heart failure, or other condition? Sometimes our documentation is just not very clear. So here's our ICD-10 similarities and differences, and a lot of you have probably already seen some of this. We have improvement in coding primary encounters, external cause of injury, mental disorders, neoplasms, and preventative care. Now, one of the really neat improvements is for your OB checks. It's going to be included in the OB chapter of the code book, which will be nice. It'll keep everything for OB in the same section of the code book. There's expanded distinction in ambulatory and managed care encounters, and expansion of diabetes and injury codes. With ICD-10, your diabetes are going to be one code now. For the most part, it will be that diabetes with nephropathy would be one code instead of having 2. So that'll save on entering more codes. There'll be creation of combination codes to reduce the number of codes to describe a condition. And there's greater specificity, as we all know, with all those codes in that book. And inclusion of trimester information in pregnancy. And one thing that I didn't add on here was laterality. So now if a patient breaks their right and left femur, we'll be able to code it. If there is a combination code, you'll only code it once because it'll say bilateral femoral shaft fracture. But if it's not, then you have to code both sides. So you code a right and a left, which before we could not code two codes of the same, so you couldn't capture it but now we'll have a digit in that number that will have right and left. So we'll have two codes, one for the right femur, one for the left femur. And basically our volumes of the code book are similar, except for you'll notice we don't have a volume 3 because volume 3 in our ICD-9 was our procedure coding. Our procedure coding is in its own separate book now. It's the procedural coding system book. It's a separate little book that has an alphabetical index and then tables to construct your code. Our main terms are still flush with the left margin, and then the subterms are indented in a little bit, and then the further you go to the right, the more specific the code. Carryover lines are 2 indents. We have strict can't even say it now. Alphabetical rules, and I'm going to try it again. A dash at the end of the line indicates additional characters are required. And that's one thing I've really put through my students. When you see a little dash at the end, and I see they skip and they don't look in the tabular, I know exactly what they're doing. They're skipping going to the tabular, trying to code faster, get their assignment done, so that's helped me. So our main term is the disease or the injury. The subterm is the site, type, or etiology. An exception to the rule when looking up diagnosis are these conditions. For congenital disorders, you'll look under anomaly. And that's the same with a lot of the conditions in ICD-9. You could see them under anomaly too. Pregnancy is pretty much the same, except for I don't think we could look under puerperal. We could look under delivery and pregnancy. And a complication of procedures, you look under complication. And late effects, we are now calling that the sequela of a disease. So our alphabetation, these rules, single spaces between words, single hyphens between words, and the S in the possessive form of the word is how they're alphabetical. The numerical entries are either spelled out in alphabetical order, and then the Roman numerals 2 or Arabic numerals 2 are listed in numerical order. So if you have a number 2, you'll be looking by the number 2. If it's spelled out, it will be in the strict alphabetical order. And our categories are 3 characters, like they were in ICD-9. A 3-digit character has no further subdivision, is equivalent to a code. So an example would be an 068. That's right, it's a letter. It always starts with a letter. And that's for abnormality of fetal acid-base balance. So you can have some codes that only have 3 digits. And subcategories are either 4 or 5 characters. And so our codes may be 3, 4, 5, 6, or 7 characters, but we always have to make sure that we have all of our characters there for it to be a valid code. In this one, you'll see there's an A on the end of it. That means it's the initial encounter, the first time they're being seen for that condition, or the first time they come in for a consult for that condition. So as I said, the first letter is always a letter, and this is because ICD-10-CM convention with all the codes begin with the letter of the alphabet except for U. So this just gives you a little difference, 3 to 5 characters in 9, 3 to 7 in 10, and you can look at this later. And this is kind of what our codes look like, has 7 characters. So 3 to 7 characters. The first 3 are the category. And then the second 3 are the etiology, anatomical site, and severity. And then the 7th character is used only in obstetrics, injuries, and external cause of injury. So in your code book, when you're looking, you'll be able to tell how many digits. I didn't bring an outpatient book. Does anybody have an outpatient book? I forgot to look in the book. Because in the inpatient book, it has a little, yeah, it's in the, to the left of your code, it has a little red box. And it has, like it says, on this one, 6. That means it only has 6 characters. So you'll know you're okay with assigning only 6 characters. If there's 7, then it will say 7 in that little red box. And we have a placeholder character when there are not enough characters there to fill up the whole 7 digits. So say you only have 4 characters, and then you have to have a 7th character of an A. So what do you put in there? You put an X in those 2 spaces that are missing, where there's nothing in there. And you can either use a small X or a large X. It doesn't make any difference. It'll still work. Here's an example of a laceration, muscle or tendon of head for the initial encounter. And then also in maternal care for fetal problem, 3rd trimester, fetus 1. Notice how there's an X in there in the 6th space? That's because there's nothing there, so we have to fill that in with the X. Okay, and our correct coding is always look up in your alphabetical, verify in your tabular, and check for your instructional notes. And we'll go over some of those in a few minutes. And making sure you have the placeholder X and the 7th character values when required. So I'm just going to go over some coding conventions. A lot of you probably already know this. It's a good refresher, I think, since we're starting a new coding system. With, in, due to, and associated are used to express the relationship between the main term and the subterm, indicated an associated condition or etiology. With and without are not in alphabetical order, but are immediately below the main term. And here's an example on bronchitis. So bronchitis is clear to the left, it's your term, and then you'll notice with underneath. So you could have with influenza or obstruction, and then it goes down to acute chemical due to. So it's an alphabet, it's right underneath the bronchitis. And then these are our cross-reference notes. See or see also refers the coder to see another entry. See category refers the coder to see another category. And see condition refers the coder to the main term of the condition. So an example on glaucomatous flex, it says see cataract complicated. And hypersensitivity says see also allergy. And multiple, it says C. So if you have like multiple conditions, you're supposed to go back to whatever the condition is. Inclusion notes are further used to define or give example of the content of the chapter, and maybe a synonym or condition similar. So an example in chapter 1, certain diseases of the parasitic disease, A00 through B99. Inclusion note states that this chapter includes diseases generally recognized as communicable and transmissible. So we have a code first note or use additional code. Manifestations of a disease in which you must code the disease process first shows proper sequencing. So here's an example with a respiratory disorder and diseases classified elsewhere. It says this code can never be the first listed code. So we know by looking at this, we've got to have another code first before the J99. So that's code first or additional code. And then code also indicates 2 codes may be required to fully describe the condition. And inclusion notes certain terms that are for the condition of which the code number is to be used. The terms may be synonyms or the code title, or in the case of other specified codes, the terms are a list of various conditions assigned to that code. The inclusion terms are not necessarily exhaustive, and that's per coding guideline 1A11. And here's an example of an inclusion note. Type 2 diabetes with diabetic chronic kidney disease. This is something we didn't have before. We had with nephropathy, but now if they have chronic kidney disease, there's a specific code for it. And you'll see it says use additional code to identify the stage of chronic kidney disease. And this is where we won't be able to use all of our chronic kidney disease codes, only the specified chronic kidney disease. If it's unspecified, N18.9, you do not add an additional code to above because it doesn't give you any more information than what you already have. So if you know it's stage 1 through 6, then you could code an additional code. In ICD-10, the code also note instructs that 2 codes may be required to fully describe a condition, but this note does not provide sequencing direction. In contrast, the code first and use additional code notes provide sequencing order of the codes. Another coding guideline. Abbreviations, we still have our not elsewhere classified and not otherwise specified. There is, for not elsewhere classified, there is no separate code for this condition. It's an other specified condition, or NEC. And this will be either in the 4th or 6th character 8, so like that digit will be an 8, or in the 5th character over, it will be a 9. For not otherwise specified, the 5th character will be a 0, or the 4th or 6th characters might be a 9. Codes title other and unspecified. For use when information in medical records provides details for which a specific code does not exist. Contrasted with unspecified codes when information in medical records is insufficient to assign a more specific code. And our term and is still the same as in ICD-9. It means and or. That has not changed. Our brackets, our square brackets, are used to include synonyms, alternative wordings, abbreviations, and explanatory phrases. And here's an example. Under HIV, the HIV is in square brackets, so that's basically an abbreviation. And then brackets are also used in your alphabetical index to identify manifestations of a disease. So this one, example is nephrology, sickle cell disease, D57, and the N08 is the manifestation of the sickle cell disease. It doesn't tell you what it is there, but that's a manifestation. Colons are used in the tabular list in both includes and excludes to define when one or more modifiers is needed following the colon in order for the term to apply. So here's an example. And this is an example of an excludes one note down at the bottom, which we'll learn about in a minute. It says irregular menstruation with, and this is what makes it, if they have lengthened intervals or scanty bleeding, shortened intervals or excessive bleeding, that's going to go in a different category, different code. So the parentheses are used both in the alphabetical and the tabular to enclose supplemental words. And another name for these are non-essential modifiers, which means they do not have to be present. Whatever's in the bracket does not have to be present in order to code this term. So if the doctor says diabetes mellitus, well, we know that's diabetes. But if they say sugar diabetes, we don't have to have the word sugar in his documentation. We can just have the diabetes there and use this code. I'm sure we're all aware of this. Here comes our 2 excludes note. In ICD-9, we only had 1. Now we have 2. Excludes 1 and excludes 2. So excludes 1 note indicates that a condition is not coded here and should never be used at the same time as the code. Above the excludes 1 note, see, it should never be used at the same time as the code above the excludes 1 note. And I have an example on spondylolysis. The excludes one note cannot code with congenital spondylolysis. You cannot code a congenital and acquired condition together. So you can't code both the acquired and the congenital together. You have to pick either or. And a lot of these are going to be ones where we're going to have to work with our physicians to get the congenital part of it out of them, because sometimes they'll just say spondylolysis and they don't ever say if it's congenital. And excludes two is not included here, but is acceptable to use both the code and the excluded code together when both are documented. Indicates that the condition excluded is not part of the condition represented, but a patient may have both conditions at the same time. And here's the coding guideline. Here's an example. Excessive weight gain in pregnancy is O26.0. And the excludes note says that if the patient has gestational edema, we can code that with the excessive weight gain. Where the excludes one, if we had gestational edema and that one, we could not code it with the other code. But excludes two means you can have both the excessive weight and edema together. Okay, and then now we're going to start our infectious and parasitic disease. The main axis of Chapter 1 is the organism responsible for the disease. So if it's E. coli, if it's staph, codes from Chapter 1 take precedence over other codes from other chapters for the same condition. So our A and B codes, which are infectious disease and parasitic disease codes, the A and the B first letter, will always go before the conditions such as meningitis. So this one, the histoplasmosis, it's the organism responsible for the meningitis, but we code the histoplasmosis first and then the meningitis. Chapter 1 is very similar to ICD-9-CM with some categories and subcategories titles changed. There is a separate subcategory for viral hepatitis and for other viral diseases. And it includes disease generally recognized as communicable or transmissible, and there is an instruction note to use additional code to identify resistance to drugs. So we have a little bit of change. Strep sore throat, I think was 034009. It's now been moved to Chapter 10. And codes are expanded to reflect manifestations. So now you might have one code instead of two, or two codes instead of one. Just depends on the code. We have a new section in this chapter, which is our sexual disorders, infections like your chlamydia, your gonococcal diseases, all the other ones are now in this category A50 to A64. And codes were moved from other sections of the code book to Chapter 1 to have them all in the same chapter, anything that is contagious or transmissible. Urosepsis is no longer a term in the code book, so if your physician ever uses that, you won't be able to anymore. So now we're going to have to ask him, do you mean UTI or sepsis? So we're going to have to find out what he means by that, since it's no longer there anymore. We have a dual classification in Chapter 1, which is your like bronchiomycosis. Now this one, the reason it's dual, because it's one diagnosis, but it takes two codes to give the full explanation for the diagnosis of bronchiomycosis. One from the infectious disease chapter, one from the respiratory. And they can be coded in two ways now: a single code from Chapter 1 to indicate the organism, such as B37.1, candidiasis of the lung, or a combined code to show the disease and the infection. And that is where J15212 is MRSA pneumonia. So that one, instead of having a or B to show the MRSA and the J for the pneumonia, it's all combined into one code, similar to what we have now in ICD-9. We now have sequela of infections and parasitic diseases in B90 through B94. And that's towards the end of the second chapter in the infectious disease. Only use these codes for the residual effects of a condition which has been treated and no longer present. So code for a condition that's still present as a result of the sequela, and do not use for chronic infections. So now we're starting on giving you a little bit of information about these disorders: sepsis, bacterias, AIDS, influenza. We don't have anything on TB, unfortunately. We didn't get that in there. Infectious gastroenteritis and our sexually transmitted diseases. So Judy's going to take over now, so be kind to her.
I'm learning as she's going.
You're always learning.
Interesting, yeah. Well, I'm Judy Parker. It's good to see you. See some familiar faces, some new faces. I'm glad to see you. Welcome. I've been coding, 9 years inpatient now, and I've been at Salem a little over a year and a half as a coder 3, answering questions and helping out with the coders and the CDI specialists. Anytime you need to call, I always say this, anytime you need something, give me a call, anytime. Of course, then people go, well, I might want to call you in the middle of the night or something. So we're going to talk about sepsis, our favorite subject, at least here in the hospital. Sepsis is a life-threatening systemic bloodstream infection. Usually it originates in the UTI, as a UTI in the urinary tract, the lungs with pneumonia. You get it with the surgical wounds and the infected Foley caths, that kind of thing. I have to get organized here. Okay. Some common causative organisms, and I wanted to show this to you so you'd see the codes that go along with this. Some of the more commons are streptococcal, staph aureus, gram-negative, and then of course then specified. And then there's some that are not in the categories A40 through A41. And those would be the disseminated herpes virus disease, which is really sepsis. But you see that it's within the B range, and candidal sepsis. And, oh, I'm sorry. Hey, just give me a heads up, okay? Yeah, could you ding, please? Just say ding. Okay, so this is my big news and I'm excited about. This is the ICD-10 spoiler alert. We no longer are going to be using the term septicemia as the principal diagnosis. It's going to be called sepsis, as it should be. The first organism is sepsis when we come to our sequencing guidelines. So any bloodstream infection will be classified to sepsis. And then that gets you where I know you're asking, well, what about bacteremia? Now, bacteremia, that refers to a mild bloodstream infection. It's usually transient. It clears pretty quickly. And it's the body's immune system that takes care of it. So even though you may have a bacteria in the blood, doesn't mean it's a systemic infection. But anytime you have a bloodstream infection that is considered as a true infection, it's going to code to sepsis. Ding. Thank you. Okay, I love this little thing because this shows the process of how sepsis starts. It starts as an isolated organism, either a bacteria, a fungus, any kind of virus, and it moves into the circulatory system where that overcomes your immune system, and then that then moves into a systemic inflammatory response syndrome. So as you can see, the infection overlaps the SIRS and becomes sepsis in the middle. And then the SIRS also gives you where you don't have the infection and SIRS by itself caused by trauma or burns or pancreatitis. I've looked at this many, many times trying to understand sepsis. It's something that you really got to get your mind around, and that has always been a big help for me. So we'll talk about the systemic inflammatory response syndrome, SIRS. So that is a response to any critical illness. And that's where you start seeing all your clinical indications. SIRS with the infection is sepsis. And then you can have a non-infectious SIRS, like I was saying, with the burns, trauma, cancer, pancreatitis. So in order to meet the criteria of SIRS, Coding Clinic, and now this is ICD-9 guidelines, and I'm sure they're going to have an ICD-10 guideline come up for this, so I just wanted you to realize I'm referring to ICD-9s, but we can use that for these purposes. For the SIRS, for the inflammatory response syndrome, you need at least two criteria. The temperature, you want to see a fever. The heart rate needs to be greater than 90. Respiratory rate greater than 20. And your white blood cell count should be greater than 12,000 or less than 4, or 10% or greater bands. And I just want to say too, I'm a coder. I'm not a clinician, and if anybody here is a clinician, let me know if I'm, giving the wrong information, and, we can get that corrected. These are things that I have, any information I'm giving you is through either our Coding Clinic guidelines, or I've gone to uptodate.com or the CDC websites so that, I could help inform you. But I know we have clinicians here that have hands-on experience, and so I welcome any suggestions. And there was this Surviving Sepsis campaign that instead of those basic criteria decided that we needed more. We needed to jump onto sepsis within the first 6 hours, and other SIRS criteria, which would be looking at their mental status. Did they have altered mental status? Do they have hypotension? And this was something I didn't realize. Hyperglycemia in the absence of diabetes is also part of the criteria. And the procalcitonin, I know we do that here at the hospital, so every once in a while, if you're trying to confirm that this patient has SIRS, you can look for that lab and see what those results are, and you can refer to this. There's 3-stage syndrome of sepsis. First, you have your sepsis. Then it can go to severe sepsis without the shock, without septic shock, which is usually associated with organ failure. And then you have the severe sepsis with septic shock, That septic shock is a subset of the severe sepsis. The low blood pressure, arterial blood pressure, is what defines that septic shock. And usually and through this Surviving Sepsis campaign, which I think was a pretty big deal. It used to be a while back, I'm not sure maybe how long, but they just kind of went, okay, it might be sepsis, maybe we'll look at it and we'll give them some antibiotics. Now they're saying within the first 6 hours you want to jump in and start giving them aggressive therapy. IV fluid resuscitation, that helps to prevent the organ failure. You want to stabilize their breathing, their respiration. Maybe they may need to be intubated. Mechanical ventilation might be required. IV broad spectrum antibiotics. And then they may need to go to ICU for severe sepsis and septic shock, where they'll have vasopressors. And this is just ways that, for the inpatient coders, they can help to determine and clarify if the patient had sepsis. It used to be that we could say, doctor said sepsis, we could code it, and that was the good old days. And then we started having RAC, and Medicare looking at things and other third-party payers, and we were getting denials based on the clinical indications that didn't match with the sepsis. So now coders have to be able to match those together. So remember, the physician documentation must support the clinical picture. Not only does the SIRS criteria, the fever, the heart rate, the hypotension, the altered mental status, all of that needs to be documented, but also they have to say the underlying cause. Was it an infection? This SIRS response, this inflammatory response, was it due to an infection or was it because of trauma? And I love this document. This is the suggested documentation for the physician. Patient presents with leukocytosis and fever. There's your SIRS, the 2. Suspect UTI as a source, meets criteria for sepsis. If they put that on everything, we wouldn't have as many denials as we could, we'd be able to boom, okay, code it, we're good, and off we go. So we simply just need to educate the physicians on exactly what criteria is needed for documentation. So, if you have a documented diagnosis of sepsis, what else do you need before you can code the sepsis? This is a question. This is your first test question. You got your documentation of sepsis. What else? Okay, that's right. You need to know where it's coming from. And the clinical indicators. Excellent. All right. And if you have the clinical indicators of SIRS without a documentation of sepsis, what do you need? What do you do? Query. Yeah, I want to hear that. I like that part. The query queens here. So we'll go into some of the guidelines for coding sepsis. First, you're going to want to assign the appropriate code for the underlying systemic infection. Now, in ICD-10, instead of it saying septicemia unspecified, it says sepsis, maybe due to staph or whatever, but at least the code actually says sepsis. And then you have your different types. I found it interesting, this is because I'm not a clinician, but strep group D actually codes to the enterococcus of sepsis, so I thought that was interesting. A negative or inconclusive blood culture does not exclude a diagnosis. So even though it may come up negative, they still can have sepsis. They need the clinical evidence of the condition, of course. And we have a case study. An 87-year-old nursing home patient is being treated with IV antibiotics for E. coli sepsis. Pretty easy one here. And if you had time to look it up in your book, you'd see A41.51 is sepsis for E. coli. Of course, you always want to go to your index and then confirm it in your tabular. And especially now, you know, we get used to using the encoder as coders, and it can lead you astray. But for ICD-10, you want to use the book as follow those steps so you don't get taken down another pathway. So if you have sepsis or severe sepsis and it's present on admission, and you have a localized infection, let's say pneumonia or cellulitis, you code the underlying systemic infection first. That would be the sepsis. And of course, that's the more acute situation that you're having, so that's going to be what's bringing them into the hospital. And then the secondary diagnosis of either pneumonia or the cellulitis. And if you did have severe sepsis, it's an R65 code that we'll go into more. But getting used to the codes with the letters in front is really a challenge. You can have a 0 or it's an O and you want to call it a 0. We're all used to saying the numbers first. So everybody's in the same boat here. So if the patient's admitted with a localized infection and the sepsis doesn't happen until after admission, then the localized infection is sequenced first because it wasn't present on admission. And then a secondary diagnosis for the sepsis code will go after the principal diagnosis. This is for inpatient coding. And then if you have sepsis that's due to a post-op procedure, it could be, I don't know, a surgical wound, any other procedure, you code the post-op complication code first. And as you see in these, they start with a T, and so they're in the T categories. And then that's followed by the systemic infection or the sepsis. And it's the same guidelines as in ICD-9. It's just getting used to seeing those letters in front. And of course, you must have the provider's documentation of the relationship between the infection and the procedure. They may say post-op infection, post-op sepsis, but that wording, that term post-op is just a time frame and doesn't indicate that it is actually a complication of whatever procedure they had done. So you definitely want to get that documented. And then we have severe sepsis, severe sepsis with a non-infectious condition. This can be, somebody comes in with third-degree burns, they have cancer, even pancreatitis can cause this. So it causes all of those criteria that we were looking at, the fever, the heart rate, the hypotension, and if I'm just looking at this. If documented as non-infectious, the non-infectious condition would be coded as the principal. So you don't have an actual infection, and let's say you have a burn with SIRS, the burn is going to be documented or sequenced first. Now, if you have the non-infectious condition, like a burn, and they come in and it leads to sepsis or severe sepsis. Then you're going to code for the R65, which is severe sepsis, R65.20, severe sepsis without septic shock, or if they have septic shock, R65.21, severe sepsis with septic shock, and you don't need to code just the SIRS of non-infectious origin, of course. They've come in with their burn, they've developed sepsis, so you're going to code the sepsis, or they've developed severe sepsis, you're going to code severe sepsis as a secondary to the non-infectious condition. And that's if the infection developed after admission. And so you'll have your burn first, sepsis, the A40 code, and then the R65 for severe sepsis, with or without shock. Yes. Uh-huh. So it starts out as a non-infectious condition. It has a burn. You just no infection yet, but you know they get into the hospital and develop an infection. Yes, it happens after admission. That's correct. Yes. Yeah, the sepsis, then it develops into sepsis after they're here, and then it becomes a non-infectious condition with an infection. I know, this is very confusing stuff. No, it just develops into a sepsis. It's nothing that anybody did wrong, but I'm not familiar with the treatment of burns, but I do know that when you've got such severity like that, that it can lead to an infection, whether maybe as much, whatever clinical treatment was given, it just happens. So it's not on the HAC list. That's the hospital-acquired condition that she's talking about, which once you put, there's a list of certain conditions that if they occur after admission, the hospital doesn't get reimbursed for that. So this is not something that, you know, in other words, if you caused a problem with the treatment and that's on that list, like a pulmonary embolism. I know that happens sometimes, but that's on the list for some reason. So this is not, and it wouldn't be considered that. But yeah, I could see how you'd think it was a complication of some kind. And then there's the postpartum sepsis, and we'll talk more about this when we get into the obstetric chapter. I just kind of wanted you to look at it and see what we've got, different codes. It's always now that's a 085, and it's kind of nice because obstetrics starts with a 0. I mean an O. Did I say 0? I'm sorry. Thank you. An O. See? It's easy to get confused. And then the newborn sepsis, we'll talk about that. Perinatal starts with a P. Okay, do we want to, how much time we got going here? Yeah. Okay, so let's just go over this real quick. When you've got severe sepsis, you're going to have a minimum of 3 codes. First, you're going to have the underlying systemic infection. So the sepsis code, the A40 code. Then you're going to have, if it's severe sepsis without shock, or severe sepsis with shock, and then any other codes for any organ dysfunction, respiratory failure, renal failure. So it's kind of nice. Before you had the septicemia code, then you had the sepsis code down below, you know, and then you had to code for the organ dysfunction, and I guess it's kind of the same thing, but I just love that the first code says sepsis and not septicemia. Then the second code is the severe sepsis. with or without shock. And this is a case study. I'll let you look at these. It's just kind of giving you an idea of what the codes look like. Now, this is meningococcal sepsis, A39. So, just gives you an idea of what that looks like. I'll let you look at these. Okay, so then we're going to start. Or do you want to take a break now? Okay. Yay, break time. This is a good time to grab something to eat. Yeah, we're going to have 15 minutes. I've got about, what, 10 after? Is that what you've got? Yeah. Why don't we come back?